Live case number 6. Put it up.
Yes, you want to show us the end of the previous case or no?
Oh, I thought it was too simple to show after that.
Okay, maybe
We
at the
did,
end of this
yeah,
case.
it was good. So we did, DCB of the side branch, and then we did.
At some point,
Actually,
you show
when
us.
we image, remember we did, and the IVUS, the vessel size was 3.0, diagonal.
You show us the final result at some point. Okay, let's go with this case.
We will, after this. So here, this is what you're seeing, a 73-year-old female, okay, who had presented with angina, shortness of breath, and some, EKG has shown some changes, significant risk factors. More important is active smoker. And I think one thing we already know that people who are smokers, two things, peripheral vascular disease and calcified coronary artery disease. Yeah. So she had a CCTA, and they said, of course, look at the calcium score, about 2600, EF was good, and showed multiple lesions you're going to say, showing it, right? LAD as well as circumflex. So heavily calcified, had a significant LAD disease, and significant RCA disease, two-vessel disease, okay? And then we did a rotational atherectomy of the LAD, stent of the LAD done. Today, if you can show the angiogram, she's here for PCI of this distal RCA.
Very complex.
Calcified, and look at how the RCA takeoff is.
Highly calcific and highly tortuous in the proximal vessel, and a very big size as well.
Yeah.
So a lot of challenges and a huge distal distribution. A lot of things at stake here.
Yeah. So we actually tried, this is a 7 French guide, we tried AL 0.75, and I did not like the way it's facing. Then I need to make have aggressive movements to actually get it coaxial. So now we change to actually Lima guide, which is sitting much better. So we will now ask the panel, yourself, how we approach. So we have various approach that we think we need to do. One would be that we thought we will go fielder fine cross, change to rotawire, okay? And then we will have to get a Guidezilla. That's why we have a 7 French. Getting a rota all the way down to the distal RCA could be challenging. We could do dyna, try to see if it will reach there with a 1 fiber, versus we get a Guidezilla, means we have to go side by side, wire, balloon, get a Guidezilla down. But when you have a 7 French Guidezilla, the max you can do is 1.25 bar. So you can get a lumen of 1.25 bar, and then do we do the same thing that we did in the other room, that then do we consider IVL to really modify that calcium in the distal RCA? What do you think?
Yeah, I mean, for sure you're going to need some sort of guide extension, and definitely the biggest size guide is size equipment. All the equipment is very necessary, because also with the tortuosity you may have to both do a lot of maneuvers as well as be able to do some injections and see what's happening and all that. So you really need the size.
So that is one option. Another option, Josun, is just thinking, why don't we just wire it or balloon dilate and then try to get a IVL down there through a Guidezilla? So that's another option that also is a possibility. But I think let's do what we initially planned. What do you think?
Yeah, I mean, I'm not sure how that's going to work. It's a very big IVL balloon. You need also, it's not a small IVL balloon. You need to go at least 4.0 here. IBL balloon.
Yeah, we have a 354 already.
Yeah, but will it deliver this big balloon through a Guidezilla? I'm not so sure. Particularly on the way out, you're going to take everything out together with it. I think better to go as planned.
Okay.
Any ideas from the Dr. Singh? Dr. Singh is here, and
no, I see your pacemaker. I know you're going to do rotablade, but the artery is pretty big. There is train track calcium in there. So, it may not be unreasonable just to take a non-compliant balloon and see how it goes in angioplasty. That, to avoid trauma in the proximal vessel and stuff like that might not be unreasonable. Even though I'm as, Anu knows, we perform atherectomy when you see these kind of things, but it's probably not unreasonable.
Yeah. Any other idea? Dr. Barman, idea from the west side of New York.
Some die.
I mean, all the thoughts are all reasonable. I think you can get quite a bit of feedback by just how the wire and the catheter behaved. It seemed pretty favorable here. So I think if you were kicking things out very early in this case, that might change my strategy. But right now, I agree with seeing how a balloon dilates.
Okay, get us
Any ideas from,
floppy wire, right?
Any idea from Europe? Dr. Moller, no idea from Europe. How about Long Island?
I agree. I think, a 3.0 non-compliant to start or 3.5. I'm just not sure what a 1.25 is going to do.
How about the Wild West of Oklahoma? Any idea from Oklahoma?
Yeah, I think for this kind of a case, certainly would consider to avoid the proximal trauma, maybe getting your guide extender down and burring through that with a 1.25, and then I think you would still probably need to do more, maybe lithotripsy.
Get me a run-through wire. What's the
Dr.
balloon you have?
Dr. Duvuri, any ideas from New York,
Guidezilla.
back from New York? Any more ideas from New York?
Okay, this is
Again, see
7
how
French.
the wire goes.
Why did you do that?
and
So
then,
you destroyed already.
Direct imaging may be difficult, so maybe get the guideliner and then image and see. Looks like the calcium is mostly in the prox and mid, and the lesion itself doesn't, at least angiographically, doesn't seem very calcified, so it may be good to know what that shows.
All right, so
No, it's calcified even at the level SD. See that?
calcified all over.
Yeah, all over.
And these kind of lesions, when you have that big of an artery and it becomes like a sausage link, is pretty high risk for no reflow also. So I know,
You want to take a picture?
vasodilators and stuff, and you see pacemakers, you either give them monofilin or you need pacemaker in here,
Okay.
because otherwise you're gonna have issues.
Okay, so this is another thing. You see, already there is a concertina effect. So it's
Yeah.
good that we took a picture now.
Yeah, how you gonna deal with the possible rotablator and the concertina effect?
Yeah, 100% it will cause a dissection, not 99, 100%.
It might be time to
So let
just
us
do
see
balloons.
how the Guidezilla will behave now, okay?
it causes
If
a
I can
dissection-
get past through that, yeah.
If it causes that dissection, we're pretty lucky. If it causes a perforation, is a concern. The dissection
Yes,
is a
that's
given here. No matter what we do, this vessel is going to have a major dissection. We're going to stent that. That will be a good thing, because this means we're going to expand everything. So let's see how it goes.
Now, once you have a concertina effect, sometimes the double wiring is not easy,
Yeah, no.
okay?
Well, you made
Went
it look
through.
easy.
Huh?
You made
Now,
it
this
look
is in the
easy.
PDA. Yeah, good. Now, get us a balloon and 7 French, Guidezilla.
3.512.
And also what happens is now, once we start this route, we got to be fast speed. Vessel can,
But you can see
Slow
that
flow,
the
lot of
vessel
things.
actually conformation has changed, which means that you have a good chance of getting balloon to yield, because it's a flexible vessel rather than very, very calcified. So it's straightened out pretty decent, so it may be more deep than superficial than you think, we hope.
how you're doing? Okay. That's a excellent suggestion.
Yeah, Anu, now that you have the rota down there, why don't you just balloon and see if it, with a 4.0 and just stand and leave the rota in case it doesn't yield? Make it easy.
Okay, I have a Guidezilla going up. Let me get it, a Guidezilla down there, okay?
Now, the Godzilla, what size is that?
7 French.
7 French.
7 French.
7 French.
Are you putting it over both
Okay, get
wires?
a balloon, 3.5, or what balloon you have?
Are you putting the Godzilla
okay.
over both wires or over one wire?
Yes, no, both wires.
Always,
The
yeah.
plan was both wires, and it's not going to go forward. Don't get, see, just stay there. Let's
That's what I'm making
balloon,
sure
and
we
then
understand.
if everyone is telling me try with a balloon, let's try with a balloon.
Yeah, I mean, this is very good technique. So 2 wires, and then when you take a balloon down and you inflate it, you actually trap the other wire, and then the guide extender inches in so nicely. So if you have a tortuous artery like that, this is the technique Anu is showing. This is what we should be using, because it's very, very important. Look at that. So
Yeah. And I think the balloon will expand. What's the size of the balloon, Anu?
3.5.
3.5.
3.5.
3.5,
Okay.
yeah.
Yeah, this,
Go.
That's 10, 12.
These big
Oh,
vessels,
man.
these big vessels always
See
work.
that? You see that, Anu? There you go.
Yes, okay, go up again.
Yeah.
So yeah, it's dilated. I am slowly advancing. You see that?
Yeah.
Gentle advancement.
I won't advance any further from the
Yeah,
thing.
yeah.
Okay,
because
okay, down, yeah.
I would
Okay.
try, I would try this balloon, come back and push it again. If this goes, your stent will go.
Yeah,
Okay, so it's telling get into the Guidezilla,
yeah, yes. Advance the balloon.
guide extension.
Okay, yeah, your stent goes, no problem.
Question is the size of the
Okay.
stent. Which size
Okay,
are
yeah,
you
now,
thinking?
no, stent, I think what length we took? 23 or 28?
28, we said.
4-0.
4-0
Okay,
only?
the
You-
thing is, IVUS is
You
open
can,
if you want.
you can
to click
actually
I
IVUS
can
it
do an
now.
IVUS.
Your IVUS will go.
I think,
So
yeah,
I would
IVUS,
IVUS it.
IVUS, okay.
Why don't we IVUS now? We
Yeah.
have all
Yeah, it's
the,
gonna be more
all
than
the
a
equipment
4-0.
ready.
I'm not taking a cine, okay?
No,
No, just IVUS it.
good idea.
Yeah, we're gonna be a little disappointed with
Take
the
the
Senate,
rotowire.
so not the-
Let's do, let's do a IVUS guided.
Cine after the wires are out.
Yes,
The radiolucent part are out, yeah.
And your pressure is good. You see, when your pressure is good, your flow is good around it. So, I mean, that's important. So I
Richard,
think-
I was on the screen.
yeah.
okay, Kiski.
Check the image. Okay, start pullback, huge vessel. It's coming.
Yeah, look
Huge
at
vessel. Yeah, yeah. It's true there was calcium, but it's modified.
Do we need a IVL or you think we can do it just direct stenting?
No,
Go back to the tightest
Yeah.
area it is.
no IVL,
So this is a
just
distal
stent.
reference is like a more than 5 vessel. And this is our lead, but looks like there's a
Okay, look like
yes.
we have
Looks
modified the plaque, right?
Yes.
Yeah.
Okay.
Looks
the
like you
vessel?
did IVL there. It cracked everything.
the vessel size distal.
Superficial
Precise.
calcium,
Yeah.
like Jas mentioned, yeah.
Dr. Kenny, there's also some another tandem lesion just after the Guidezilla. There's
Is it
another.
random lesion or is it?
No, that's
I think that's pseudo lesion.
That's a pseudo lesion, yeah.
Yes.
There is no plaque there.
Yeah.
Yeah, there's no plaque, it's a pseudo lesion,
Yeah,
which Kiskil, come here, look at this. This
Yeah,
is something, another teaching point. When you
graphically.
get that kind of a tortuous vessel, after you wire, before you get any of your devices down, document a cine. So you know what is a true lesion and a pseudo lesion. See, look at the angio.
Angiographical,
Yeah, yeah, you see that, yeah, that's what I'm probably seeing with IVUS. So what should be the IVUS? So we probably wanted
Yeah.
to do a 4-0-28.
No, but what's the size of the
okay, so-
vessel? What is the size of the
Yeah.
vessel distally?
So this is distal to the lesion.
The diameter.
Okay, lumen is 4 vessel is
Okay.
like 5 vessel.
Vessel is 5-0.
Maybe
No,
four, five.
no 5-0. I think it's probably going to be 4-0 stent,
No,
right?
no.
probably end
It's
up
a
with the
larger
full
vessel.
Area of activity.
You know what? It lot is ectatic. Even putting a 4-5 stent, I'm a little worried. Why don't we go 4-0 and it's easy to post?
Yeah,
No,
4-0,
Pedro,
4-0,
what do you
because
think?
the
No, that
artery,
is what I think we should do. No?
artery is remodeled, and if you take a bigger stent, you'll perforate it. You don't want that. You just want
Yeah,
to make
yeah,
sure
yeah.
you size it
So
according
did we
to the
decide length?
vessel.
I said 28. Kiski, what's your?
Shortest normal to normal minimum length is 22.
Why
20?
so long?
22.
22. Okay,
That's
give me
the size
28.
of the lesion,
quickly.
22, the length?
4-0, right?
Yeah, 4-0-24 then. Or
No, he's saying that,
4-0-23.
no, 23.
Yeah,
What
23,
also,
yeah.
we are not going to give dye. We don't have that luxury. So just put a long stent, then remove the Guidezilla, and then you decide.
Oh.
But we need to post it, right?
Yeah. Maybe post it before we come out with the Guidezilla.
Okay, then what, 4-5 you want?
Yeah, get a 4-5, 12 high,
No, 15. What do you have, 4-5?
15, yeah.
Okay, so we have to remove the rotor wire.
Beautiful.
Okay, I'm taking out the rotor wire. You want to give a little, I'm going to get the Guidezilla back a little bit of dye. Pressure is okay, right?
Yep.
Just
Ready?
a gentle, yes. Okay, wait. Okay, good. Okay, now here.
It's good that the stent doesn't come near to the proximal tortuosity, so we're not going to have this
Some more dye?
straightening effect. Perhaps a dissection at the edge of the stem. A little bit further in.
You want more in? No, no.
Yeah, it has to
that
go more
seems
in.
okay. seems okay.
Yeah, I think we are good. We're good.
A lot of pseudo lesions.
Pulling back a little bit. Yeah, that's a pseudo lesion there. Yeah. Pulling back. Okay, good. Okay, it didn't move. Okay, go up.
Going up.
Came back.
Get us the high pressure balloon. Down. Yeah, what length? Okay. Yeah, 12 is good. Go up again. I advanced the Guidezilla just because if the high pressure balloon may not go.
Yeah.
So we had the rotor wire there, which we took it out. And now we post dilate and then we image. It's a big balloon, wait for deflation. Give me this syringe. Deflation may take time.
And double deflate.
And the EKG is behaving, so.
Yeah. To get us a post dilation and then we do a quick IVUS, then final picture. What's are we doing a next case or are we doing next lecture?
We have three
To tell
cases
the
in a
other
row.
room.
I'm waiting,
Huh?
I think I'm waiting to hear if the next cath lab is ready.
Can you check?
I haven't gotten a confirmation yet, but seems like from your point of view, we may be ready to go to the next case in a few minutes.
I think the beauty here is going to be when you remove that wire, the radiolucent, and that thing goes away.
Yeah. Is the wire too far, Anu? PVC?
Done. We are done. We are all
Probably,
telling.
it's probably the pacemaker going in and out.
Okay, go up here. I'm going to remove the pacemaker. Okay, stop
Turn
the
the
pacemaker.
pacemaker off.
Yeah, there you go. Take it
Since
out.
it, okay, yeah.
That's 14.
And
Okay, down. I was ready.
predilate the more proximal too, Anu. Yeah, beautiful.
Yeah, I am here. Yeah.
Sure.
Here.
Yeah, I would probably go for
We're not
sure.
going. We are not going real high pressure. We are like 16. Okay.
I think it's
And-
going to be,
and-
on the
and-
IVUS, it's going to be well opposed on the plaque,
Okay, good.
but it's going to be undersized for the vessel size. With the 4.5 may be okay.
Yeah.
You go up here. You want to go higher?
You know,
Let's,
16. 18.
let's give a little nitro and see how
Okay,
it
good.
goes.
I was ready. No, I think let's IVUS EKG good so far. And at the end, we will remove the
No,
wire.
I'm saying
remove
we
the
got to give a
Guidezilla.
little nitro before the IVUS, that's what I'm saying.
Oh.
a little verapamil, like, but we don't have the pacer anymore, no?
No.
You guys wanted it out?
Now we want it back in.
Now it's a mega RCA.
Yeah.
Okay, so nothing wrong if somebody says, I want a
The
pacemaker.
next case is not ready,
If
so
there
we'll have
was-
to extend our time. Put pacemaker back in.
You going to IVUS now, Anu?
Yeah, I'm going to IVUS now.
Yeah.
And we're going to give a little bit of nitro. Okay. Nitro here to keep everything going.
It
Okay,
just,
good.
somehow I don't like that Godzilla down there.
No. We'll come up because, listen,
Your-
after
your-
IVUS,
Your
I'm
pressure
taking
is
it out.
good, you know, you have a big balloon, 4.5, sometimes you pull it out, you know, Anu is very methodical, you want to let it bleed back
Yeah.
because otherwise you suck in
Yeah.
so much air.
Oh,
When
yeah.
you inject nitro and stuff, you cause no reflow
Yes.
with
Okay.
air, so.
Can you show the IVUS?
Okay, hold on.
Yeah.
Look,
It's not there yet.
you don't
yeah.
have wire purchase? Yeah, it's not there. It's going now.
It's, you may have some plaque protrusion, that's why you're having difficulties. It's a lot- it's a
Okay,
huge-
just do what you can.
Yeah.
It's not
Agree.
that aggressive.
Start to
Yeah,
look.
Yeah, pull back. Does it
yeah.
look okay?
I see the protrusion.
Wherever we
there.
are.
Looks great.
Proximal edge,
Very expanded.
This came back too fast.
well opposed.
Well, we can't see
Now-
because it's foreshortened. So let's take it out and release some
No.
some
Let me do one
tortuosity
thing. Let me
before
take
we
this out.
see what's
So,
happening.
yeah.
No, the stent looks perfect. There is no dissection and stent is well opposed.
Yeah.
And-
MSA
Exactly.
is like 10.5. So, Doctor, can I show it to you again, please? So, this is proximal to today's lesion. There's also another carcinoid lesion, nodule lesion.
Okay, what's the MSA there?
It shows like a
Okay,
to
now,
something
Yeah.
before our lesion.
And just bleed.
okay, bleed.
Now
Looks like
that's-
this is a
Okay,
focal carcinoid
then
nodule
we're
lesion.
going to give some nitro.
Yeah.
I think that was the area where you had a
Exactly.
wire bias, right?
Yeah,
And
yeah,
then
yeah,
That's
yeah.
the.
Wire
that's the
bias is
pseudo
making
lesion.
it 2.7,
Yeah.
okay?
Well, let's see now. Why don't you give a little dye now? Yeah.
Yeah, looks
Yeah,
good.
it's gone.
Case is done, case
Yeah,
is done,
case
go
is
to the
done.
next room.
Yeah,
Wire
You ready?
out, good picture, low mag.
Go.
Let's go for the next case.
yeah, yeah.
Hold on,
yeah,
hold
yeah.
on, low mag.
Low mag.
Hold on.
So okay, and we need to get the orthogonal view as well.
Beauty. Bravo.
Well, the distal is
What
just
we,
a little
what we
bump.
learned, complex
good.
case made simple,
Absolutely.
right? No, orthogonal
Well,
view
it
events.
was
So
a
let
thought
us do an
process.
RAO view
No,
here.
it's how the things behaved and how the bias was. You avoided complication. I mean, this is a very, very instructional case. You don't get hell bent on doing orbital or rotational and stuff. Just see how the artery responds, and that's exactly what you did, which is
I don't
which
think
is
it's helping
amazing.
us. Maybe the straight cranial be better.
But the
No,
teaching.
that, we want to one thing, that is it a true lesion or is it a pseudo?
Yeah, that's
And
right.
let us bring this, what's called as Hitchcock's window, so that you can see. Poor man's IVUS.
You're gonna do RAO?
Yeah.
Go more,
just-
go
I don't like
45.
normally.
Go more RAO.
Yeah,
Okay.
maybe little.
No, it's no more. I'm more going Mario.
Little caudal. will
Well, let's
open up
take
that
this
area.
picture and we adjust because it's
Yeah.
tortuosity is very eccentric.
Yeah.
Yeah, a
I
little
would
bit.
leave everything alone.
I think it's great.
Right?
Your proximal edge of the IVUS looked amazing, so I wouldn't touch it. It looks
Yes.
good.
No,
Yeah.
I will not.
Yeah, perfect.
Okay, low mag, because
All right,
Bravo, Anu, bravo.
wants low mag.
excellent. Are we ready in the next cath lab? We can proceed.